Good afternoon. My paper is based on a very simple observation. We need ILM peeling which is transparent, and so we have to stain it with brilliant peel, which is most commonly used. And most of the times if we don't visualize the ILM properly, we try to stain it again, and most of the times the persistent vitreous remnants or ERM etc. or a poor contrast, they prevent it. Now what happens if you don't see it well? You can end up traumatizing the retina. You can have a retinal hemorrhage. Commonly we just do a restaining or a FG with a restaining. Now this study was basically aimed to know whether we can do a restaining with after picking up the first initial ILM pick, and it is based on a simple observation that the scrolled ILM edge always stains better than intact ILM. So this is a prospective interventional non-comparative clinical series which was done. 20 consecutive patients were stained, 10 underwent pick and stained, and 10 were just underwent restaining itself. After completing the vitrectomy, the staining was done with BBG, okay, and the evaluation was done by the operating surgeon, but it was a very subjective evaluation, and the ILM staining was known, just graded as whether it was good, faint or absent. The ease of dissection was not considered because it is due to various other factors than the staining itself, and the patients underwent a complete ophthalmic checkup post-operatively to know if there was any toxicity for restaining it after the initial pick. So when we did the results, we observed that the operating surgeon found that the stain pick and stain method, all 10 cases they had a better contrast, and the visualization of the ILM was better as compared to the restain, in which they felt it was good in 4 cases and fair in about 6 cases. There was no evidence of any retinal pigment or retinal epithelial or nerve fiber defect seen in any of the post-operative visits of the patients. Now this is just to illustrate how it is. This is a case of retinitis pigmentosa with macular hole. Now here purposely I have taken a large amount of pick for demonstration purpose, and then when you just restain that particular area and you wash off the ILM, you can see the scrolled edge showing much better as compared to if you just restain from the other areas of the ILM which was stained. And this is particularly useful either for people who are just learning the macular hole surgery or are the beginners. This technique will be useful for them, or in complicated cases like this in which there is a foveal myopic foveoschisis. So observe here that I've just done the first ILM stain with BBG, and unfortunately hardly any contrast seen. So wherever I could see a bit of a staining, there I have just done the first pick, okay, and then I restain it, and when the dye gets washed off, you can see the fluttering edge of the ILM very clearly. So it gives you the visualization of the ILM much better, and then you can go ahead and do the dissection. Now because of the myopic nature, the contrast, you lose the ILM in between. Here again nothing, just go ahead and restain it, and again you will see the fluttering edge of the dissected part of the myopic. Here you can see the dissected part of the ILM. You can restart from there and go ahead and complete it. So the basic reason is the vitreal side of the ILM has the epiretinal cellular or fibrocellular proliferation or the vitreous remnants compared to the retinal side. There have been studies which have shown that the epiretinal side has as much as 58% of remnants as compared to only 23% of cells seen on the retinal side. So even if you do a transmission electron microscopic examination, it will show that, as in this paper, you can see that the retinal side, which is in the slide A, which shows the retinal side, it shows just a bit of undulation and not much cellular proliferation as compared to the vitreal side, which is slide B. And this is the basic reason why the scrolled edge stains better than the vitreal side. So in discussion, basically the cellular and vitreous remnants interfere with the uniform BBG stain. So the peak exposes the more uniform retinal side of the ILM. This gives you more contrast and helps in ILM dissection. However, the limitation of the study was it was very objective in nature. There was no way we could actually quantify the contrast which has been improved. And of course, it can have a surgeon's bias and a very small size of the study itself. Thank you. Thanks a lot.
Thank you, sir.